Good morning, and here we are. We are starting again with our podcast. We were taking a little break due to COVID and trying to avoid spreading the infection. And we have our guest again, Dr. Alex Foxman, who was with us a few years ago when COVID just hit.
That's right.
Welcome, and why don't you tell us a little bit about you and introduce yourself, because you have a lot on your plate and you do a lot of good stuff. So why don't you tell us?
Sure. So thanks for having me back first. I'm excited and privileged to be back. My name is Dr. Alex Foxman. I'm a board certified internal medicine physician, and I have a couple of innovative practices. The first being Mobile Physician Associates. We are a completely mobile group medical practice. We provide medical care to the frail, elderly, and disabled population of Los Angeles County and Antelope Valley, with all of the services that you could get in a doctor's office. The medical providers, the laboratory, x-ray, ultrasound. The goal for us is to keep people in the community. That's very important. We want to prevent emergency room visits, hospitalizations, nursing home care. We really believe that seniors and those who have disabilities have the right and should have the opportunity to live their entire lives in a community setting. So that's very important, and that's what I do for the most part. I also have a private medical practice in Beverly Hills called Beverly Hills Institute, where we take care of all different types of patients and provide them preventive care and chronic disease management. And I also have a completely virtual medical practice, which is quite new, called Achieve Health and Weight Loss. And here we provide medical weight loss management to our patients, not only in California, but in 32 states, using healthcare oversight, remote scales, health coaches, and innovative medications, which many people have begun to hear about, such as Ozempic, Wegovy, Mounjaro. Those are some of them that we use and have amazing results with that. But today we concentrate on
infectious disease.
Infectious disease, correct.
Yeah, at first when you walked in, I didn't recognize you lost so much weight.
I appreciate it. Thank you.
Well, let's dive right into it. So I do want to speak about, since COVID is kind of sort of behind us, even though we will live with it, I do want to, the topic is infectious disease, and specifically resistant strains, bacterial infections like MRSA and VRE. But before we go into that, can you please educate our listeners about the difference of what is a bacterial infection and a viral infection?
Sure. There are big differences, and it could get very complex, but I'll make it very simple. A bacteria is a single-celled organism that could live outside or inside their host. So bacteria are everywhere right now. Bacteria are on our table, no matter how clean we keep it. They're on our microphone, they're on our hands, they're on our clothes, they're inside our body, they're outside our body. And these bacteria many times are required for us to have a normal life, a normal metabolism. For example, if it wasn't for the normal healthy bacteria that live inside of us, we would be very sick. We would have weight issues. We would have issues with our digestion, immune function. So bacteria are very vital, healthy bacteria are very vital for us. Viruses are organisms that cannot live outside their host. In other words, they need the host to be able to multiply, divide, and spread to others. So it's a big distinction with that. The way viruses and bacteria are treated is very distinct and important as well. Bacteria, for example, require sometimes nothing, but sometimes antibiotics, specifically for bacteria. Antibiotics help reduce the not only reduce the replication of bacteria, but also could destroy and kill the bacteria based on the different processes. But they also have problems as well. So we could always talk about that as well. The problems with giving too many antibiotics. Antibiotics do not work on viruses. Viruses only can be treated with either our own immune system or antiviral medications, specific medications that are geared to stop the replication of viruses while they multiply. So it gets more complex from there, but that's the
for our general audience. I think
Sure.
we don't want to get too complex, because
Sure.
then I don't want to lose anybody. But so let's kind of sort of dive into the how a specific strain of bacteria gets resistant, like MRSA or VRE. And the reason why I want to talk about this is because in long-term care facilities, and that includes assisted living, skilled nursing facility, hospitals, certain things are prohibited. In RCFEs, or assisted living in the state of California, you are not allowed to have a resident who is officially diagnosed with MRSA or VRE or any infectious disease that is not treated, unless, and there's a condition, right? Unless it's colonized or it's if you either colonize or if you're on a specific, if you're in a hospice or things like that. But I would like to talk about really how does a bacteria gets resistant, number one, and number two, I want to also see if you can elaborate a little bit about what do you think we should do to prevent, once you have it, how do you prevent the spread of such infection? And let's talk about, first let's talk about bacteria, VRE, MRSA, and maybe there's some other ones that I'm not aware of.
Sure. So as I said before, bacteria, for the most part, do not cause any sort of problems for human beings. In fact, they live on us and in us, and it's very important. But you have to think about any living organism as something that wants to survive, thrive, multiply, and continue on. It's no different with us as human beings. If the sun is giving us a sunburn, we put on a shirt. If it rains on us, we try to build a roof. If something hurts us, we try to protect ourselves. It's the same thing with organisms like bacteria. They want to also survive and thrive. So if we try to destroy them, they will try to build mechanisms through normal evolution processes to protect themselves. So when we provide bacteria with antibiotics, this bacteria is meant to harm the bacteria, to kill it, eradicate it. So the bacteria over time becomes smarter. It learns how to get around these obstacles of antibiotics. And that's what drug-resistant bacteria are. They're bacteria that have evolved to be more resistant to many, and sometimes all, of the current antibiotics that we have. Which brings us to a completely different point we could talk about later, which is why do we use antibiotics and how do we use them appropriately? But currently, we now face a problem with what are called drug-resistant bacteria. And typically, these come from places where we use a lot of antibiotics all the time, such as hospitals, medical clinics, nursing homes for the most part. And what essentially happens is that these bacteria, they become drug-resistant, and then they colonize initially, or they infect the human host. And that's a very big distinction also. Being colonized with a bacteria simply means that you have something living on you that is not causing you any harm, that if you swab that bacteria, will be drug resistant. But it typically won't cause you harm. Okay, now sometimes it can, but when you have an active infection with a drug resistant bacteria, that means it's infected either your skin, causing sores and wounds and things like that, or your urinary tract, causing urinary symptoms such as urinary tract infections and so forth. Sometimes it could infect your gastrointestinal tract, causing stool infections. It can infect your lungs. It can infect even your bloodstream. Those are active acute infections. And those are the ones that you were talking about before, that if a person has an active infection with a bacteria that is drug resistant, you shouldn't keep them in your facility, in your assisted living facility, because the fluids that are infected could cause harm to others if it splashes on them and so forth.
So what happens if you're colonized?
So if you're colonized, is different. Colonization is not harmful, and the chances of you being infected by someone that's colonized is very, very low. As an example, let's just take the most common current bacteria that cause resistance.
Okay.
Let's start with MRSA.
Okay.
MRSA stands for methicillin-resistant Staph aureus. Many of us have staphylococcal bacteria on our bodies. No problem. But as time went on and we gave a lot of people antibiotics for reasons they should have gotten them or not, these bacteria, these staph bacteria, have now resistance. And the resistance is to a type of antibiotic called methicillin type antibiotics. And these bacteria, when they colonize our body, may not cause problems, but when they become more aggressive, they can. For example, people sometimes get what's called cellulitis, an infection of the skin, and there's MRSA cellulitis. It's more difficult to treat. We have to treat it with specific other antibiotics to be able to eradicate it. There is MRSA sometimes that could be in the urine. It could be in all sorts of other bodily fluids as well. So when it's on a person's skin, even guidelines even say, look, you don't have to wear special gowns. You don't have to wear special things. All you have to do is we have to perform proper precautions, infection precautions, which we could talk about as well, simple things. You could kiss your loved one. You could hug them. It doesn't mean something's going to happen. But if someone has an active infection, you do have to use things like gowns. You have to be extra cautious, sometimes wear gloves to be able to protect yourself. Be more hygienic than you typically would be before, not only for yourself or for the person with the infection. But once that's cleared, a medical provider that's licensed could then make that person not an active infection, but a colonized infection, which brings them back to a normal state of not needing extra precautions.
Which is safe.
Which is safe.
Okay. So does this mean, so first of all, can you treat or can you cure, I should say, not treat, can you cure an MRSA or a methicillin-resistant bacteria?
It's very challenging because this bacteria is all over the person. And, if you swab, let's say, everyone not in a healthcare facility, because that's a much higher number, but if you swab the general population, MRSA is in about 1% of the general population.
That's a lot of people.
It's a lot of people. Okay, just not knowing it even, just positive. In any healthcare setting, including the medical providers, physicians, extenders, nurses, staff, and patients, you're looking at probably upwards of a 30% potentially MRSA infection rate, carrier rate, okay, colonized rate. That's because we're constantly exposed more to this. Now, it doesn't mean that we are, we have to wear the scarlet letter. It doesn't mean that we're somehow infectious to other people. It just simply means that we have a bacteria now that is more resistant to antibiotics.
So, does this mean that? So wait a minute. So, everybody has some sort of an infection, right? But you said it's not dangerous. So, my question to you: by having it on your skin, right, and it's colonized, for example, is it better in a way that your body will build immunity by being exposed to it, or is it not good? What I'm trying to get at is, I heard that, some people are always going and washing their hands, and I heard mixed reviews saying, oh, it's not good because then you have no bacteria and therefore you have no immunity, versus you do have some, what I'm talking about?
Sure,
so something
sure.
that can make you stronger naturally versus taking bacteria, antibiotics, or things like that. And same thing I think applies to allergies. I've heard that people who are exposed to peanuts at a very young age, most likely, and I don't know if it's true. This is more of a question rather than a statement. But I heard people who are exposed, for example, to peanuts or food items that contain peanuts, will most likely will not have or will have less allergies to peanuts rather than those who have never been exposed to it. Is that true?
Well, we can start with infectious diseases, for example, first. Okay. One of the reasons, there are very few reasons why human beings are living longer. Okay. And those are, we have lots of technology and lots of therapeutics and so forth. But the reason why we're living longer lives is for several very basic reasons. The first one is sanitation, infection control. That has caused humanity to live much longer because we realize that there are things that could infect us. So proper sanitation, proper food storage, proper use of things like antibiotics have extended our life expectancies. So that is something where I wouldn't recommend for people to just say, let's build immunity by not washing our hands, by touching our eyes, nose, and mouth all the time. That's not where we should be. But there are studies that show that, for example, children who are exposed to environmental antigens and allergens tend to have less allergic reactions and allergies later in life than children who do not. So living in a sterile environment is something that I wouldn't recommend in terms of children, and that children should be out and exposed to the normal environment. But also children, like everyone else, need to know basic infection control, because that could save everyone from major problems, including these things we've talked about before with COVID and things like that. What are basic precautions? Washing your hands. Okay, washing your hands with warm soapy water, at least counting to 30 when you wash your hands. is very important, okay? If you're using gels, the antibacterial gels, using the gel before and after you see someone is very important, because when you use it before, you don't bring that person anything, and when you use it after, you don't bring it out. Very simple stuff. Not touching your eyes, nose, and mouth. In medicine, in our residency, in our medical school, we're always told to, kind of hold your hands like this, even in surgical environments. Because when you don't, the way viruses and bacteria get into your body are through your eyes, nose, and mouth. This is the way they actively infect the inside of you. Not ears. Well, they could be ears, but eyes, nose, and mouth is the best way. So if you keep your hands away from that, you significantly limit infections, okay? So those are just very basic types of things that we could do to help us out.
So now that we discussed about bacteria and you brought up COVID, let's talk about viruses. First of all, what is your recommendation, or what is your opinion about vaccination? And let's gear this more towards older adults, say 65 plus. And also, what do you recommend? What kind of vaccination do you recommend for them to receive, and at what age and at what frequency?
Yeah. So vaccinations is another reason why human beings are living longer. Without vaccinations, without us being able to cure polio, without us able to be able to cure smallpox, without all these things, I think we'd be in a much worse position. Now, there's a lot of controversy about vaccinations, especially with the COVID vaccines and so forth, and that might be for a later date. But what I would say is that keeping especially the elderly, 65 and over, vaccinated by the recommendations of their physicians is vital for their long-term longevity. There are many preventable infectious diseases, viruses especially, that could be used and that could be prevented by vaccinations. So some of the vaccinations that I would recommend, okay, going in no particular order: annual influenza vaccination,
the flu.
The flu vaccine is not meant to prevent the flu. The flu vaccine is meant to prevent unnecessary illness, such as hospitalizations and death. In fact, any given year, believe it or not, between 20,000 and 80,000 people just in the United States die from flu-related complications.
Oh, wow.
And the vast majority of them are because they weren't vaccinated. So we never really look at that, but we have very bad flu seasons and very good flu seasons. But on average, between 20 and 80,000 people die from that. So that's an important one, once a year. The second one would be pneumococcal vaccinations for pneumococcal pneumonia. There are many strains of pneumococcal pneumonia or pneumococci that could cause harm. And there are several vaccines that I recommend. And what they do is they cover different strains for infection. There's what's called Prevnar 23, and then there's Prevnar 13, which is now being replaced by Prevnar 20. The reality, the basic part is that if you're immunized for all these different strains, the chances of you having a bad outcome or dying from that is quite low. And again, about 35,000 people every year, just in the United States, succumb to a pneumococcal type of pneumonia. Okay?
These are big numbers.
These are big numbers.
How are they compared to COVID? When I say COVID without vaccination, let's compare apples to apples. So you don't get, let's say you don't get vaccinated for COVID and you don't get vaccinated for the flu.
Yeah.
How are they comparable, number-wise?
So we have to look at the time when we compare this. When COVID was first discovered and started infecting human beings, the mortality rate was between 0.5% and 2%. Okay? Those are significant mortality, because that particular year, this was the first year that the COVID-19 virus was exposed to humans and humans were exposed to them. And the first year is always when you get the worst infectious rates, the worst outcomes, because the infection is much more severe. If we look at COVID, how it's mutated to this date, it's very likely that the mortality rate is much, much lower, because it's a different type of virus we're dealing with right now. It's highly infectious, but still a different type of virus. So it's very hard to say. Right now, probably the mortality rate is about 0.5%. But the most people who get problems with COVID-19, if we want to just stick to that for a second, are the elderly, and especially those who have chronic conditions and so forth. But they will be the ones that will have problems with not just COVID-19, but with the flu, with pneumonia, with all sorts of other conditions. So I still recommend further immunizations for that particular population. Going back to, and that's one of them that I still recommend for boosters and moving forward, is for the elderly population at this point. There's then also vaccinations for shingles. I don't know if most people know what shingles is. Shingles is a remanifestation of chickenpox. 99% of the human race has had probably chickenpox. Yeah. But what happens is that this virus doesn't go away. It lies dormant in our nerve cells, in our spine typically. And when we get older, that virus then wakes up and then crawls up the nerve endings and can cause a very painful blistery rash called shingles, and it could happen anywhere on the body. If you're lucky, it happens on your back or somewhere where it's not that painful. If you're not lucky, it could happen on your face, in your eye. It could cause paralysis. It could even go to your brain sometimes as well. And it's a very major problem.
And what age do you recommend getting that vaccine?
That starts at the age of 50. And it's a 2-dose vaccine.
I'm not there yet.
Yeah, it's a 2-dose vaccine currently called Shingrix. It's the gold standard at this point. And that vaccine typically protects you for about 25 years. Now, it doesn't guarantee that you will not get shingles, but it certainly significantly reduces the severity of it as well. By the age of 80, 1 in 3 people that are not vaccinated for shingles will get shingles. 1 in 3. Wow. 33%. So it's a very big number and a very preventable disease process. Okay? So those are some of the major ones. I'm thinking of any other ones that I recommend.
So flu vaccine, shingles vaccine, COVID-19 vaccine. These are the 3
pneumonia vaccines.
Oh, pneumonia vaccine. Okay. So 4. We got 4.
Yeah,
that you highly recommend, and they are
effective and safe. As much controversy there is out there, these are safe and effective. They're not under any sort of emergency use authorization, which is where I think right now we're having a lot of the controversy, is having vaccines that have not gone through the rigorous trials that the FDA would need for them to be shown to be safe and effective for long term. COVID vaccines were necessary to be fast-tracked. And yes, there are now some side effects that are coming out, such as in the younger populations, potentially with some heart issues and so forth. But for the elderly population, I truly believe that the benefits of getting the vaccine far outweigh the risks, because many elderly cannot take any sort of viral infection, and this would be just another one that could really cause them to have a bad outcome.
Well, listen, I think we covered quite a bit in, it's about, I think we're around 30-minute mark. And
time flies.
Time flies when you're having fun, right?
Yeah, sure.
So is there anything else that you think we should kind of mention in this podcast to our audience before we conclude this?
Look, I take care of, in my organization, Mobile Physician Associates, takes care of many patients at assisted living facilities. And I could tell you that for the most part, if everyone does their part to practice good hygiene, good infection control, and understands the difference between bacteria and viruses that are infectious and infective at the time versus those that are colonized, I think that it would be a much easier situation for everyone. And I think education is the source. Washing your hands, making sure you're wearing the right clothing. For example, I wear scrubs. Why do I wear scrubs? Because we've deemed ties to be highly pathogenic in terms of all the bacteria that live on them. Many people don't launder them properly, and so I no longer wear ties. But if we all know that we shouldn't be freaked out about bacteria and viruses, that they're part of our normal existence, and how to properly manage them, I think that everything should be fine.
Well, listen, I want to thank you for this very informative podcast about infectious disease. I learned a lot. I knew a little bit, but I learned a lot. And hopefully our audience will gain the same knowledge as well. And until next time, thank you very much, Dr. Foxman. And we will see you hopefully sooner than later.
Anytime. I'll always be here.
Thank you.
Thanks.